Hello, everybody. Welcome, welcome, welcome. Tonight, I have something extra special for you. Our guest is Dr. Jonathan Barratt, nephrologist and IgAN researcher from the University of Leicester in the UK, talking about Tarpyeo treatment. Dr. Barratt leads the Renal Research Group at the University of Leicester. I hope I'm pronouncing that right, Doc. His research is focused on a bench-to-bedside approach to improving our understanding of the pathogenesis of IgA nephropathy, a common global cause of kidney failure. Jonathan is also the IgA nephropathy rare disease group leader for the UK National Registry of Rare Kidney Diseases and a member of the steering committee for the International IgA Nephropathy Network. He works closely with pharmaceutical companies interested in new treatments for IgA nephropathy and is the chief investigator for a number of international randomized controlled phase 2 and 3 clinical trials in IgA nephropathy and was a member of the FDA and American Society of Nephrology Kidney Health Initiative, identifying surrogate endpoints for clinical trials in IgA nephropathy work group, as well as studying the fundamental immunological basis of this rare glomerular disease. Jonathan also studies the long-term physical and psychological impact of living with kidney disease. He has written numerous articles, and I do mean numerous articles on kidney disease, which have been published in highly recognized professional journals. Tonight, we are going to talk about Tarpyeo treatment for IgA nephropathy patients. Please give a warm welcome to Dr. Jonathan Barratt. Doctor, how are you tonight?
Great, thank you. It's really nice to be here, Jim, and thank you very much for the invitation.
Well, I'm sorry for all the mispronunciations in the introduction, but did I state everything else correctly?
Yes, so I've had a career-long interest in kidney disease and in particular rare kidney diseases and IgA nephropathy. So yes, I do a lot of research in that area from the laboratory all the way through to understanding how this disease affects patients' lives.
Please tell us a little bit about where you grew up, your education, and your employment experiences.
Yeah, so I'm born and bred and lived all my life in the United Kingdom, and I studied medicine at the University of Manchester in the north of England, where I met my wife. And very early on, I knew I wanted to be a nephrologist. I was very impressed by kidney doctors that I worked with as a medical student, and I realized that I wanted to be someone like them. So I specialized in nephrology. I trained in Manchester, in Leeds, and in Leicester, which is slap bang in the middle of the country. And in Leicester, I did my PhD researching how IgA interacts with cells in the kidneys itself to cause inflammation and scarring. And really from that time as a PhD student back in the early 90s, I've really got a great interest in the research of kidney disease and have developed a research team and collaborations across the globe to develop new ways of looking at this kidney disease. So I work with colleagues in the United States, all the way across through to China and Japan, all the way over to the East and everywhere in between. So we have a fantastic network of interested doctors and scientists whose goal in life is to try and better understand this disease and try and find cures for patients.
Great. Let's talk a little bit about IgA nephropathy. What is it? And can you describe for us what happens with the kidneys?
Yeah, so I think if you think about your kidneys, each kidney contains around 1 million filters. And those filters are like sieves, and they sieve the blood every second of every minute of every hour of every day. And they essentially clear the blood of toxic substances and excess water, which is what we pee out every day. and we get rid of those toxins from the body. And those filters need to make sure that the bad things come through into the urine and the good things that the body needs stay within the bloodstream. And if you imagine the filters as a sieve, they're highly complex sieves that have very specific properties that only let certain things through into the urine. And what happens in IgA nephropathy is that those filters become inflamed. And when they become inflamed, the holes in those sieves get slightly bigger and slightly damaged, which means they start letting things through that shouldn't be appearing in the urine. And the two things that we look at, and if you're a kidney patient, you will know that nephrologists are always looking for, is we will see blood, cells, and protein in the urine. And that's because they've been able to leak across this damaged filter and get into the urine. And we can detect that with a dipstick, or we can see it under the microscope, or we can send your urine off to the laboratory, and we can measure the amount of protein. And what we are doing there is we're using that to kind of get a guesstimate of how much inflammation and damage to those filters has happened. And those filters are called glomeruli, and any inflammation within there is called a glomerulonephritis. And IgA nephropathy is just one form of glomerulonephritis. So in IgA nephropathy, the things that causes the damage to those filters is the deposition of big clumps of protein into those filters, and that protein contains this molecule called IgA. And IgA is an antibody, we all have it. It does great jobs. It stops bacteria and other pathogens getting into the body because it's in our tears, it's in our sputum, it's in our gastrointestinal juices, where it sits and it binds to bacteria and stops them ever getting into the body. So it's a really important antibody that we have. But in IgA nephropathy, some of this gets into the bloodstream rather than going into our sputum or going into our tears or our saliva. And it was never designed to be in the bloodstream. And when it's in the bloodstream, it starts sticking to itself and to other proteins. And that's what causes these big clumps. And it's those clumps, when they go through the filters of the kidneys, that start getting trapped. And when they get trapped and they accumulate, that's when all the mischief starts. And that's where the problems start within those filters. And this disease happens over many, many years, as there's just very slow buildup of these clumps of protein in the filters. And there's a gradual damage occurring to those filters. There's increasing blood and protein getting into the urine. And that damage to those filters eventually causes scarring and loss of those filters. And unfortunately, as soon as we lose a filter, we can never replace it. We only have as many filters as we're born with. And so what happens is, if you lose too many of those filters, you develop kidney failure and you start accumulating all those toxins that the kidney normally gets rid of every day. But when you start accumulating them, that's what makes you feel poorly. And that's when, if they accumulate to such an extent, that's when we need to start thinking about giving you dialysis or giving you a kidney transplant. So that's kind of like a whistle-stop tour, but essentially, this is a disease of the filters of your kidneys.
Okay. What is an autoimmune disease? What does it do?
So an autoimmune disease is a disease where the body is attacking itself. And this can affect any organ of the body, and it can affect multiple organs simultaneously. In IgA nephropathy, what we think happens is this IgA that I was talking about, that should be in your sputum or your saliva, but is for some reason ending up in your bloodstream, is a protein that doesn't normally exist there to very high levels. And so it's detected by the body's immune system, and the body thinks, well, wait a minute, why is that there? It's not normal. Could it be something that's going to cause us harm? And so the immune system reacts to that and generates antibodies to try and deal with it, to try and get it out of the bloodstream. The problem is, when we develop antibodies, so this autoimmune process, it simply makes those protein clumps bigger, because the antibodies react with the other antibodies, and you can imagine they build on one another, and these clumps of protein in the circulation get bigger, they get stickier, and as they pass through the kidney, they stick in the filters and cause more damage. So while the immune system thinks it's doing something right, it's actually doing the complete opposite by reacting against one of our own proteins and making the disease worse by making these clumps of proteins bigger and more likely to deposit in the kidneys.
Okay. How common is IgA nephropathy, and particularly among which group of individuals will we find it?
So if you think about my practice, and this is probably similar to you guys in the US, I look after a population of 2 million people. And we will make a new diagnosis of IgA nephropathy between 20 and 30 times a year for 2 million people. So it is a rare disease. If you compare that to diabetes, you compare that to asthma, you compare that to having cancer, this is a rare disease. So it's estimated that in the United States, there are around 200,000 people living with IgA nephropathy at the moment. And that's roughly the same number in Europe. So it is regarded as a rare disease. But as a kidney doctor, it's one of the things that I see a lot of, because that's where I'm particularly focused on. But for patients to understand, your general practitioner will probably in their career only look after one patient with IgA nephropathy. And that really puts into perspective what your expectations need to be when you go see a general doctor, because they'll only possibly ever see one person with IgA nephropathy in their career. And therefore, they're not likely to know that much about it. And they're likely not to be able to give you all the information that you need to know about the disease.
Okay. I've heard you speak before, and you talked that this disease is more common in Asian and Caucasian people, usually not diagnosed, somewhere in between their late teens to late 30s. Did I understand that correctly?
No, absolutely. So we know, if we look at a map of the world, that the incidence of IgA nephropathy increases significantly as you move from the west to the east. And IgA nephropathy is far more common in East and Southeast Asia, so in countries like China, Japan, Malaysia, Thailand. And not only is it more common, but it's more likely to put you on dialysis if you are East or Southeast Asian. And that applies equally whether you're living in East and Southeast Asia or whether you have emigrated to, say, Europe or the United States. And so we can see very clearly that there's a great study out of Canada that looks at all the patients looked after in Toronto. And they can show that even in a patient population with access to the same healthcare system, access to the same drugs, managed in exactly the same way, that patients of East Asian and Asian Pacific origin have worse kidney function and progress and lose their kidney function faster than Caucasians. And so we don't understand why that is, but we know it's a fact. We also know that this disease is very uncommon in people of African descent. And that's different to other kinds of kidney disease, which are more common. But actually, IgA nephropathy, if you look into Africa and people of African descent, is an uncommon cause of kidney disease in terms of compared to Southeast Asians and Caucasians. And you were quite right. This is a disease of younger people. Most people present in their 20s, 30s, 40s. Even at that point, most of those patients have established kidney disease with impaired kidney function, even at that age. And so it becomes a real challenge for us, thinking about how we manage patients to prevent them developing kidney failure in their lifetime, where most of these patients will have 30, 40, 50 years to live with this disease.
Okay. What are the symptoms of IgAN? What should a patient look for when they're trying to decide if they should go see the doctor that they may possibly have this disease?
So this is the real challenge with IgA nephropathy, because by and large, it doesn't produce many symptoms at all. The classical presentation is for young people, young teenagers, to pass fresh red blood, so visible blood. It may look red, it may look Coca-Cola or tea colored, around the time that they have coughs and colds, so respiratory tract infections. That's a classical presentation. Often the pediatricians see that presentation. As adult kidney doctors, we don't tend to see many adults present like that. For me, most of the time patients present because they've had their urine dipsticked, they've had their blood pressure checked, or they've had a kidney function blood test for a completely different reason. And someone has found out it's abnormal, and that's triggered the referral to kidney doctors. So in terms of IgA nephropathy, it is a asymptomatic disease. And actually, that's why we diagnose it late, and why sometimes we don't diagnose it at all, because patients don't have symptoms. And therefore, without a test looking at the urine, or without a blood pressure measurement or a kidney function blood test, we don't know the disease is there.
Okay. Is it frequently diagnosed via kidney biopsy?
Yeah, so you can only diagnose this disease with a kidney biopsy, which means that patients will need to be referred to a kidney doctor to make that diagnosis. And different kidney doctors have different thresholds for doing a kidney biopsy, and patients on the call may well have had different experiences of what it takes to get a kidney biopsy, but we can only diagnose the disease with a kidney biopsy. I see along the bottom you have back pain, and that's a really interesting thing, because we looked at what patients with IgA nephropathy were talking about on social media in the UK. And one of the commonest things they complained about was loin or back pain. And we really don't understand why that's the case. And we're doing a study at the moment to look into that. But I think there may well be symptoms we don't naturally think are associated with IgA that may well be associated, but we haven't done the research yet. So I think you do raise an interesting point, that actually there may be symptoms we haven't quite grasped are important in IgA, but that we are doing the studies to try and look at that.
In addition to lower back pain, would that be things like blood in the urine, foamy urine, swelling in the feet, ankles, or legs?
So foamy urine is so foamy urine is an indicator of high levels of protein in the urine. And so if you think about that, you don't necessarily need to have foamy urine to have protein in the urine. If you see blood in the urine, it's really important you see your doctor straight away, because there are lots of different causes for seeing blood in the urine. One of which is IgA nephropathy, but there are other important causes you don't want to miss as well. And swelling of the legs is really a late sign of general kidney disease, because that tells you that your kidneys aren't getting rid of enough salt and water, and that's accumulating in the legs. But that's not, again, specific, and you can have IgA nephropathy without having those symptoms.
Would it be fair for me to say that when IgAN is diagnosed, some kidney damage in most cases has usually occurred?
Absolutely. So when we have just published some data looking at the UK experience of over 4,000 patients with IgA nephropathy in the UK, and the commonest kidney function we see in patients at the time they're diagnosed already shows that they have significant kidney scarring. And so that just reflects the fact we don't have a good way of identifying these people early enough.
Okay. Let's talk about disease management. First of all, is there a cure, or has there been a cure in the past for this disease?
Unfortunately, we don't have a cure at the moment, but over the last 5 years, we have had a massive activity looking at different treatments for IgA, many of which are currently going through late phase clinical studies at the moment. So the hope is that with a combination of these new treatments, we may well once and for all be able to get this disease under control. Whether that will cure the disease, I'm not sure, but I think we will be able to do much, much better than we ever have been able to do in the past with these new treatments.
From my understanding, in the past, the way that IgAN is normally managed, this is by limiting sodium intake, reducing fat intake, which are not necessarily great methods of treating it. Is that a fair statement, doctor?
Yeah, so what every patient with IgA nephropathy should be offered is general lifestyle management. So being an ideal weight, reducing the amount of salt in the diet because that impacts on your blood pressure, eating a healthy diet, and regular exercise, not smoking, and drinking alcohol within the recommended limit. So those are general advice we give to any patient with kidney disease. And then, very important in IgA nephropathy, as with all other kidney diseases, is to make sure your blood pressure is controlled. And that will require potentially 1 or 2 or 3 different types of tablets. But the major tablet class that we want to use are something called ACE inhibitors or angiotensin receptor blockers. So ACE inhibitors, it's easy to know because they always end in pril. So captopril, enalapril, lisinopril, or an angiotensin receptor blocker, which always ends in a sartan. So irbesartan, valsartan, losartan. Those are the drugs we really want to use because they help blood pressure and they also reduce the amount of protein in the urine, which tells us they're protecting these filters. So those are the drugs that we would commonly use. And more recently, within the last 12 months or so, we now have a new class of drug called SGLT2 inhibitors, or the fliglosins, which are a new drug initially designed to treat diabetes. But actually, there have been large studies that have shown that these are both protective for the heart and protective for the kidneys in kidney patients. And so you might find that actually your nephrologist wants to put you on a drug such as dapagliflozin or empagliflozin, this new drug which you take in addition to your ACE inhibitor or ARB, because they have good general protective effects on the kidneys and on the heart.
Okay. Is it true that until recently there have been no disease-specific treatment options for IgAN?
No, you're absolutely right. In a perfect world, we would want to give a drug that targets the fundamentals of the disease and stops the production or movement of this form of IgA into the bloodstream, and therefore stop these protein clumps from forming. And we really have had nothing. The only drug that has been used to any great extent is prednisolone or prednisone, the corticosteroid. And that's been used at high doses to try and help reduce inflammation in the kidneys. But it comes at a great cost. It comes at a cost because of side effects that patients really, really do not like. And it also comes at a hidden cost because it impacts on your blood pressure. It can make you diabetic. It can impact on your bone health. And so these are drugs that we've had for many, many, many years, and we've used them out of necessity because we've had no alternative. But the great news is we are starting to get safer and better tolerated treatments coming that are as good, if not better, than the steroids that we've used in the past.
Okay. How are patients with IgAN monitored? How do you check and see how they're doing in terms of progressing toward kidney failure?
So one of the first things is to empower patients to be part of that process. So I encourage all my patients to own a blood pressure machine so they can record their blood pressure regularly. Keeping an exercise diary, keeping a measure of their weight so that they can ensure they're at an ideal weight. And this gives patients a sense of control and a sense of ability that they're contributing to their own health. In addition, we will see patients regularly, and what we generally do will be a blood test to measure the kidney function. And for that, we measure something called creatinine in the blood, and we then use that value to convert it to something called a GFR value, an eGFR value. And in very rough speak, the eGFR value equates to roughly the percentage of kidney function you have left. So if you have an eGFR of 50, and that's in mils per minute, that equates roughly to you having 50% kidney function compared to someone who's healthy. If you have an eGFR of 10, then you only have 10% of kidney function compared to someone who is healthy. So the lower the number of GFR, the more advanced your kidney failure is. And just to make things more confusing, the worse your kidney function, the higher the level of creatinine. So as your creatinine goes up, your GFR goes down. And then the other thing that we measure regularly is the amount of protein that's leaking in your urine. And that's usually done on a spot urine sample. And what we will measure is something called a protein to creatinine ratio or an albumin to creatinine ratio. And though either of those will tell us how much protein is leaking through and how damaged those filters are. And it will also tell us whether the treatments we're giving are working, because if they're working, the amount of protein in the urine should go down.
Okay. Talk to us a little bit about what IgA1 is and what its relationship is to the gut and how this affects kidney damage.
So, as I said, the IgA that we think is fundamentally the problem in this disease is the IgA that's normally produced at what we call mucosal surfaces. So those are the surfaces that line our respiratory tract, our gastrointestinal tract, and our genitourinary tract. And that IgA does a perfectly good job in all of us of stopping pathogens getting into the body. But as I said, when it crosses into the bloodstream, that's when it causes problems, because it was never designed to be in the bloodstream. It was designed to be in our secretions. And when we think, if we were just to lay out the parts of our body, then actually the gut is by far the biggest part of our body, the biggest producer of IgA of any part of the body. And so there's a lot of interest in something called the gut-kidney axis. So how does the behavior of the gut actually cause kidney disease? And in IgA nephropathy, we think the gut is the factory that is generating the IgA that is ultimately getting into the bloodstream and causing those deposits in the kidneys. And because the gut is so big, it is the largest contributor of that form of IgA. So if we think about this disease, actually I trained as a nephrologist, not a gastroenterologist, but actually as a nephrologist, I need to start thinking, how can I design treatments to target the gut to protect the kidneys? Because we think the gut, as I say, is the factory that is churning out this IgA that is the fundamental problem in this disease. Okay.
Let's talk about a treatment specifically that has been designed for IgAN that you have been working on. Can you tell us a little bit about that? And I've misspelled the treatment every time I wrote it. So if you could please tell our audience the correct spelling, I'd appreciate it.
Yeah, so bearing in mind, we think the gut is the factory for this IgA. In a perfect world, it would be lovely to design a drug that gets to the gut, targets the gut, reduces the amount of this IgA coming into the bloodstream, but doesn't actually get absorbed into the rest of the body, because that's when we get side effects from drugs. And so this drug, which is called Nefecon, which is the drug name, and its brand name in the United States is called Tarpyeo, which is Tarpyeo, is a therapy specifically designed, it's a steroid that's specifically encapsulated so that the drug is only released in a certain part of the gut. And that part of the gut has the highest concentration of IgA producing immune cells in the body. And so the rationale behind this approach is give a medication that delivers an oral tablet that delivers this steroid directly to the part of the bowel that is the most productive of IgA, with the rationale that that will then reduce the amount of IgA produced by that part of the bowel and therefore reduce these protein clumps developing and depositing in the kidneys. And because of the way the gut works, this drug is mainly metabolized as it goes to the liver before it even gets to the circulation. So all those awful side effects you see when you see patients taking prednisolone or prednisone, you won't get with this particular form of steroid, because most of it's metabolized and destroyed by the liver before it even gets into the bloodstream. But what it's doing is it's locally being released and coating that part of the bowel, and then it's permeating into those tissues and affecting those IgA producing immune cells. So that's the rationale. And would you like me to talk about the clinical studies that have been done with this drug?
Yes, sir.
So we've had two large clinical studies now, one of 150 patients and one now of 360 patients, where patients have been given either this drug at Tarpyeo or something called a placebo, which is a dummy drug. And we've looked at the impact of this treatment on the amount of protein leaking in the urine and the kidney function over a 2-year period. And what these studies have shown is that giving this drug Tarpyeo reduces the amount of protein leaking in the urine at 9 months, after 9 months of treatment. And this drug is given for just 9 months. But even though this drug is just given for 9 months, if we look 2 years after the start of treatment, we're seeing protection of kidney function. The patients on placebo have lost significant kidney function, and the patients on Tarpyeo have lost less kidney function than those given placebo. And so even though you're taking this drug for 9 months, the effect is long lasting, and you're still seeing an effect 2 years later in terms of not only the lower levels of protein in the urine, but also better kidney function. And this drug is well tolerated. It doesn't come with all those side effects of prednisone. It doesn't come with the infection risk and with all the other things that we see when this drug has been used in the past. So this is a real advance and is the first ever drug to be approved by the FDA in the United States for the treatment of IgA nephropathy, which is a world first, because it's the only drug anywhere in the world to be approved for IgA nephropathy, the first drug.
Can this product be used in the treatment of children?
So the trials have only been performed in over 18-year-olds, so adults, and that's really how trials are performed to get a drug registered. I am aware that this drug is being used in people under the age of 18, but that is not what it is approved for. But then if you look at pediatric practice, virtually every drug used by pediatricians is not approved or has been tested in children. They have used the data from adults to translate to pediatric practice. So it hasn't been formally tested in children, but I am aware that pediatricians are certainly using this drug in older children. So we're talking about teenagers rather than, kids under the age of 10. But that again is something that's done on an individualized basis.
Okay. Can you talk about the way that the drug is designed, what's unique about it, and why it works the way it does?
Yeah, so the whole issue with this drug is that there's been a lot of effort taken in formulating it in such a way that the drug is not released until it hits what's called the terminal ileum, which is the last part of your small intestines, so that the active drug, the budesonide, is only released at that part of the bowel that contains the most IgA producing cells. Because if it's released earlier, it will be absorbed into the circulation, and then you will have high drug levels in the circulation, and those levels are what determine side effects, which is what we know patients really do not like. And so the whole rationale for this medication is the way that the drug has been packaged, and that's what's so unique about this product.
Okay. Is the medication still in clinical trials?
So the clinical trial has finished now. That was following 360 patients for 2 years. There is what's called an open label extension, which is when those patients who are in the study have come to the end, they are given the opportunity to have the drug proper, or as a second course potentially, or as a first course if they had placebo first time round. And that study is ongoing. And so in that situation, the patients and the doctors know they're getting Tarpyeo, and we're following those patients to see what kind of responses we're seeing. And that will tell us how well a second dose of the drug works, or we will see the impact of the drug for the first time in patients who had 2 years of getting the dummy tablet, the placebo. So that data is currently being collected together at the moment.
Okay. As I understand it, the results of the study show after 9 months a significant drop in protein in the urine and a positive effect with your eGFR in that same 9-month period. Is my understanding correct?
Yeah, absolutely. So the drug was approved by the FDA on the basis of the amount of protein reduction that was seen in the urine at 9 months. We now actually have the 2-year data for all 360 patients. And that's what I was talking about earlier, which shows very clearly that this drug protects kidney function, and that over the full 2 years of the trial, we see that even at 9-month treatment and 15 months off treatment, we are still seeing protection of kidney function at 2 years. And that data hasn't been published or presented yet, and it will be presented shortly this year, in a short while this year. But that's really exciting because it shows you that this drug can have effects long after the treatment has stopped. And that we still think that that effect may well persist beyond 2 years, but we need to collect that data to show that effect.
Are there people that should not take this medication that are automatically excluded?
So I think there are certain people who have certain types of IgA nephropathy where this wouldn't be recommended. So the first is in a patient who's losing kidney function very, very rapidly. And that's someone who has a very rare type of IgA that is a very severe form. And in that situation, we would recommend a different treatment regime. Those patients were excluded from the trial, and so we don't have any data on Tarpyeo in that situation, but they would be excluded. Also, patients who have what's called the nephrotic syndrome, where they have very low levels of protein in their blood, very high levels of protein in their urine, and often have very severe swelling. Those patients, again, we would recommend they would have a different treatment course. And then there are those patients who have really advanced kidney failure. So those people with GFRs down in the 20s, below 20, where actually it's likely the kidneys are so badly scarred that actually whatever we do, we are not going to change things. And there the risk of any form of treatment outweighs any potential benefit, because we don't think there's any likelihood for benefit in that situation. So those are the situations where it's very clear, and then we would very much personalize the approach of the treatment to the patient in front of us. But other than that, if you've got a kidney function above 20 to 30, if you've got higher levels of proteinuria, protein in the urine, suggesting that you're at risk of progressive kidney failure, then that's where the patient that we would want to consider this drug.
Does the medication have side effects, and how well does it work with other medications?
So I think the first thing is that this drug works very nicely with the current treatments we're giving for IgA nephropathy in terms of those ACE inhibitors and ARBs, because every patient on the study had to be on those drugs. We don't have much data in terms of how this drug works with those new drugs that I talked about, the SGLT2 inhibitors like dapagliflozin and empagliflozin, but I'm sure that data will come. We wouldn't suggest that you use this drug with other tablets that impact the immune system, just because we've got no data on how safe that would be. And in terms of side effects, the commonest side effects were a minor variation on what we see with systemic corticosteroids. So there are some of the side effects that we see to a much greater and severer extent with the systemic prednisolone, but we also see in some patients, because there is a little bit of absorption of the steroid into the bloodstream. And so here we're talking about potentially short-lived acne, perhaps a little bit of weight gain, a rounding of the face, and some suggestion that there could be an increased risk, short-term risk of increases in your blood sugars. But what we know is that these all reverse when you stop the treatment. And actually, over the course of the 2-year study, these side effects really occurred when you were on the drug, and they resolved spontaneously when you came off the drug.
Okay. How long should people take this medication before they come off of it?
So the speed at which we know whether it's working or not varies from patient to patient. And so the standard treatment cycle is for a 9-month treatment course. And that's what I will recommend to my patients is don't think if after 2 weeks you've not seen a difference, you should stop it. It's not a drug that works like that. It is going to take time to see the benefit. And so for me, it's a 9-month treatment course, and I would only stop it if the patient was having severe side effects. I would want to wait the full 9 months before working out whether the drug was truly impacting on protein in the urine or kidney function.
Okay. What are the dosing rules for patients taking this product? How many times a day and how much, that sort of thing?
So the tablet it's a 16 milligram dose, which you take once a day, and you take it once a day for 9 months. And then when you come off it, you have a reduction to go from 16 milligrams to 8 milligrams for 2 weeks, and then you stop altogether. So it's a straightforward once a day treatment. It's 60 milligrams, which I think in the United States is four 4-milligram tablets, but I could be wrong there because I'm not quite sure how the formulation is in the States, but it's a 16 milligram dose every day for 9 months.
Okay. Talk to us about Tarpyeo touch points. I understand that helps people. Can you talk to us about how it helps?
Yeah, I mean, I think I'm no expert in the US. I haven't practiced medicine in the US, but when you start a new treatment, there can be lots of negotiations between the patient, the hospital, clinician, and the insurance company in terms of how you can access the treatment, and where you can get information about the treatment. And touch points really helps to try and bring all of that together to support the patient through the journey of starting the treatment and gaining access to the treatment. And this is an initiative that's been put together by the company that make the drug to try and help patients through that journey, which can be very challenging, particularly whenever you start a new drug, trying to learn about it, understand how to use it, what you might expect, what side effects you might expect.
So you get things like my notes tell me support with help with finances, doorstep delivery, information about resources. The first couple of times you use it, a nurse educator comes to your home and makes sure you're doing it correctly. Are these all things that you understand are part of touch points?
Yeah, absolutely. These are things that really make the patient journey that much easier, because patients aren't experts, and being told you have this disease and getting information about it, understanding what the right treatment is, understanding how you access that treatment, it can be very, very complicated. We as clinicians do not make people's lives easier. Neither do the health systems, either in the United States or in the UK. So these are real challenges for patients. And the touch point is really there to try and smooth the journey for the patients and make their lives easier.
Okay, we're in the home stretch here, Doc. Are there any new projects that you are currently working on that you're free to talk to us about?
Yeah, I mean, I think it's a really exciting time for clinical trials. We've got lots of new clinical trials that are recruiting, and anyone out there who's listening who has IgA nephropathy, what I would suggest is there's something called the Kidney Health Gateway, which is a US initiative. If you go onto the Kidney Health Gateway and you're interested in being involved in a clinical study, you can pop your details in and they will find studies that might be available to you where you live in the United States. I think outside of clinical trials, one of the big initiatives we're involved with in the UK is surveying our patients to find out what it's like living with IgA nephropathy. What symptoms do you have? Because one of the things you mentioned was loin pain or back pain. And we really don't understand why that develops in IgA nephropathy. And one of the things we're going to do is we're getting focus groups, we're getting patient surveys, and we're going to try and understand that in more detail. And we're going to do some experimental studies to bring patients up to our hospital when they have back pain and we're going to scan them to see whether the kidney changes size and shape when the pain is there, and then we're going to bring them back when there's no pain to see if it returns to normal. So we're going to look at the kidneys in great detail to work out, is this actually a flare of the disease, and should we be managing that with a new treatment to try and reduce the inflammation in the kidneys? So I think there's lots of exciting work happening, not only in the UK, but in the US and in other parts of the world. And the good news for people is that the people who are interested in IgA nephropathy are working very closely together, so we can share our ideas, share our data, so that we can help people who live across the globe who are trying to manage their lives with IgA nephropathy.
Are there any final statements that you would like to make to our audience tonight concerning your work or new treatment, anything of that sort? Did I forget anything?
I don't think you did. I mean, I think if you don't know about it already and you have IgA nephropathy, please take a look at the IgA Nephropathy Foundation page. It is a great organization whose sole purpose is to support people living with IgA nephropathy. If you don't know about it, there is an annual Spark Congress, which this year is happening in Washington in July, where patients get together and chat about living with IgA. We've got a variety of lectures and information to give to patients. I'll be there. There'll be people, other nephrologists and experts who really be there to want to share their knowledge with patients who are going through that journey. Relatives, children, spouses, everyone is welcome. So please take a look at the IgA Nephropathy Foundation website. And I think the most important thing is this is the golden age of IgA nephropathy in terms of new treatments. If we'd had this conversation, Jim, 5 years ago, it would not have been as exciting. There really was nothing happening. We are now on the cusp of potentially having 2 new drugs approved for IgA nephropathy each year for the next 3 to 4 years. All of them work in slightly different ways, which means the best thing in the world is we're going to be able to mix and match those drugs to the patient in front of us. So we can personalize that treatment to maximize effectiveness and minimize side effects. And the only way we can do that is if we've got drugs to choose from, and that's what's coming. So that is what is incredibly exciting at the moment for patients and for doctors looking after people with IgA nephropathy.
Okay, Doctor, I can't thank you enough for taking time today to educate us about IgAN and the new product Tarpyeo. And I'm really excited for my friends that have IgAN. And such a great job you did tonight. Thank you for talking to us and raising awareness and helping to educate us on what's new and what's going on in terms of Tarpyeo and other new products that can help patients, particularly IgAN patients, kidney patients.
Well, thank you for the invitation, Jim. It's been a pleasure.
All right. I've got a couple of things I have to finish up with our audience. I'm going to let you go. I know you're a busy guy. And just so people know, it's 8 o'clock at night where he is, and he was kind enough to do this with me. So thank you again, Doctor. I can't thank you enough.
Thank you. Bye-bye.
Bye-bye now. Everybody have a good evening. All right. So that's our broadcast with Dr. Jonathan Barratt. Wow. Tremendous information for IgAN patients. And check out the new medication, Tarpyeo. And I'll see you guys later. You have a good evening. And I think we'll be broadcasting for real. I think it's July 5th. So you guys have a good night.